Thank you for the kind introductions and invitations for me to speak in AOCCN. My topic is EEG coma patterns and prognosis. I will speak in two different aspects. The first one is EEG characteristics related to severity and prognosis. And second is EEG patterns related to certain etiology. For severity and prognosis, we usually describe EEG according to these parameters on the left, including amplitudes, frequency, morphology, distributions, rhythmicity, and reactivity. For amplitudes, if the amplitudes are attenuated or suppressed, we know that the prognosis is worse. Attenuations here is defined as more than 10 microvolts but less than 50% of the background, whereas suppressions is defined as less than 10 microvolts. The frequency will help. For those with low frequency, especially delta, is usually worse than those with theta frequency. However, for certain coma patterns, for example, alpha, beta, and spindle coma or delta theta coma, we know that alpha coma in fact has a poorer prognosis compared to beta or spindle comas. The morphology may not help directly, but it may help in diagnosis, which includes slow waves or periodic complexes or epileptiform discharges. For distributions, those with more generalized abnormality are worse than those with focal abnormality, whereas those with more rhythmic slow waves are usually better than those which have a non-rhythmic or polymorphic slow waves. Reactivity is an important characteristic in EEG, especially related to coma. The first one is reactivity to sensory stimuli. For those EEG with no reactivity, for example, the EEG, they are neither become more attenuated or faster with sensory stimulations. For example, pain, touch, or cold, they are usually more severe. Those who evolve are possibly having a seizure and they may respond to anti-epileptic drugs. The last one is that for those with continuous patterns is more severe than those with intermittent patterns. So I'll use these three as an example to illustrate my points earlier. Those EEG on the left is better as compared to the one in the middle and worse on the right side. Firstly, the amplitudes on the left is higher, smaller on the middle, and suppressed on the right. Secondly, the frequency is faster on the left, which is mainly theta waves, whereas on the right, on the middle is delta, and they are polymorphic as well as on the right, we can't see any definite slow waves. Morphology is also different. The one on the left is slow waves, whereas the one on the right is suppression. Suppressions, background suppressions, which has poorer prognosis. Distributions on the left are mainly over the frontal regions, whereas in the middle or on the right are rather diffuse. The rhythmicity is present on the left with rhythmic theta, which we can see here, whereas in the middle is mainly polymorphic delta slowing, whereas on the right side is a suppressed background, which similarly has poorer prognosis. As you can see in the middle, that there's a blue line which indicate a call, and there is no response of the EEG is related to call. This is supportive of non-reactive EEG, indicating a poorer prognosis as compared to the one on the right, on the left side. Secondly, the one on the left are intermittent slowing, whereas in the middle on the one on the right has continuous abnormality. Another way to determine the severity is based on EEG coma patterns. There are specific coma patterns that I'll discuss here. Firstly, beta coma, followed by spindle coma, alpha coma, theta delta comas, upper suppressions, and electrocerebral inactivity. As you can see here, alpha coma are usually related to anoxic brain damage, and they have a poor prognosis. Similarly, in those with burst suppressions, although it can be due to drugs, But if we have excluded that, then the more likely etiology will also be anoxic encephalopathy, which also indicate a poor prognosis. Beta coma is different from normal beta activity. As we can see here, there are beta frequency waves, but it was present throughout the EEG. It's diffuse as compared to the central frontal distributions in normal beta activity during drowsiness and sleep. They are in excessive amount, which is near continuous throughout the EEG recording. They are not reactive to sensory stimuli, and their amplitude is slightly higher than normal beta activity. And the common causes are drugs, especially benzodiazepines, rarely barbiturates or other drugs. And in the rare conditions, it may present in hypoxic ischemic insults, but these are not commonly seen. Spindle coma is also different from spindle activity in sleep. We can see that there are spindle activity, but they are rather diffuse as compared to frontal-central distribution in sleep. They are interspersed with some slow wave, which we can see over here, and some slow wave over here as well. And most importantly, it is continuous or diffuse, and they are non-reactive, not like normal spindles, which is only present in sleep and disappear in wakefulness. This implies damage to the reticular formations, but there are no consistent anatomic lesions in the pathological studies, and there are somewhat better prognosis if we see a spindle coma. The common causes include head trauma, which was first described, but also present in encephalitis, anoxia, brainstem, or other insults. Alpha coma is not commonly seen, and we can see here there are mainly alpha frequency activities, but they are rather diffusely distributed, especially in the anterior region or frontal regions, as different from a normal alpha activity in the occipital regions. These alpha activities are not reactive, and sometimes they are transient in anoxia and may progress or evolve to a more severe patterns like burst suppressions. These are commonly seen in those with hypoxic ischemic insults. They can be seen in pontomesencephalic lesion as well, and or rarely due to drug intoxications. In this EEG, you can see in the middle that patients was given a painful stimuli, and there is no change in the alpha pattern before and after the stimuli. If this is a normal alpha patterns, the alpha activity may become attenuated with stimulations. Burst suppressions. Burst suppressions consists of two components. The first component is burst, and second component is suppressions. Burst is in fact a disorganized brain activity. You can see there are fast, spiky activity and sharp waves, and mixed slow waves sometimes. And their amplitudes are also variable. Some are rather small, some are larger in amplitudes, and some of them are multifocal. The spikes are not always confined to a region. It may be present sometimes more in the frontal regions, sometimes more in the central or some fast activity in the parietal occipital regions. And they didn't follow a specific epileptiform patterns or distributions. And these waves are usually accompanied by suppressions, which is less than 10 microvolts. And suppressions can last from 2 to 10 seconds, or sometimes even longer, up to 30 seconds, or longer still with some anesthetic agents. They are non-reactive to stimulations, and the common cause or correlations are drugs, especially barbiturates or anesthetic agents. However, we can see this in hypothermia, but more commonly seen among those with anoxic encephalopathy, which indicate a poor prognosis. Rarely we see this pattern in the post-ictal state or in a very late status epilepticus. The last pattern I would like to describe is electrocerebral inactivity, which we also call electrocerebral silence. Firstly, they are absent of any EEG activities. And to prove that, we must make sure we have set the sensitivity up to 2 microvolts per millimeter in order to identify a very small amplitude brain activity. And we should record at least 30 minutes to ensure that there are no other brain activities which can be seen. Sometimes we see slow wave or some fast activity in between during the EEG recordings, but these are mostly related to artifacts. For example, pulse artifact, respiration artifact, especially related to ventilator machines, and sometimes there may be other artifacts as well. There is no EEG reactivity to intense somatosensory auditory visual stimuli, which we usually perform this during our brainstem test. ECI alone is not enough to make the diagnosis of brain death. Brain death is still depend mainly on brainstem test. However, if the brainstem test is unable to be completed or the EMIC test is inconclusive, then we may use EEG as an ancillary test. But we should do it at least 24 hours after the initial insults, which are usually irreversible. If the insults are reversible, for example, drugs, hypothermia, metabolic electrolyte abnormalities, we should wait even longer or until these abnormalities are corrected. Sometimes EEG will help us to determine the underlying etiology as well. For example, triphasic wave in coma can be due to metabolic encephalopathy, but rarely related to anoxic or hypoxic encephalopathy. Triphasic wave is a generalized periodic complexes, and we know that in generalized periodic complexes, there are a possibility of it being a triphasic waves. And firstly, we must understand what are the characteristics of triphasic waves. Firstly, the morphology consists of a small negative waves, a big positive sharp, followed by negative slow waves in 3 phases, which we call triphasics. And they should present bilaterally and synchronous between both left and right. They are mainly frontal predominance, and they should have anterior posterior or posterior anterior leg, which I'll explain or show you example later. And most often they are state dependent, where it's more prominence during wakefulness and disappear less prominence during drowsiness. These are 2 examples of triphasic waves. The one on the left is due to metabolic encephalopathy, and the one on the right is related to anoxic or hypoxic encephalopathy. As you can see here, they are both generalized, especially here frontal predominant and bilateral synchronous. The one on the left side as well as the one on the right side are synchronous. They occur at the same time. They are periodic. In this case, it happens about 1 to 2 times every second. They are having a triphasic morphology with a small negative, big positive, and a slow wave subsequently. And they have an AP leg with an anterior posterior spreading patterns. As you can see here, the waves on the anterior region start first with a gradual involvement of the posterior regions of the brain. And there are intermixed slow wave in between. And in this case, the patient also has state dependency, whereby the wave become less prominent in drowsiness and sleep. Whereas for those with anoxic encephalopathy, similarly, they have generalized, which are bilateral frontal predominant waves. They are periodic in nature, which is about once every second. They are triphasic morphology waves. They are having AP legs, but there are suppressions in the background, which is different from the one on the left side. And they are not reactive to sensory stimuli, and sometimes we label this as generalized periodic epileptiform discharges, with some of them with triphasic morphology. The next etiology in coma is non-convulsive status epilepticus. The clinical signs are unable to reliably make or exclude the diagnosis. A lot of times, patients are just unresponsive and we are uncertain whether they are underlying electrical activities unless we do an EEG. So the indicator for EEG include previous seizures, or if the patient have known epilepsy, or patient have fluctuating consciousness, or their consciousness without any explainable origins. The EEG patterns include periodic discharges, as we can see here, which occur every seconds, or they may be fast activities, and sometimes we will see rhythmic slow waves. For periodic complexes related to non-convulsive status, as we know, we always have to differentiate whether these are epileptic or non-epileptic, mostly structural causes like strokes or tumor or bleed. And there are certain features which will help us determine whether the periodic complexes are of epileptic origins, which include clear onset offset, evolutions, frequency, amplitude, and distributions, clinical correlations, disappear benzodiazepine, and sometimes whether they are having PLEP plus with some fast activity intermixed with the periodic discharges. And I'll explain these features a little bit more using the examples. So these are patients who are non-responsive, but we can see that in the beginning, there is an onset of an event with a rhythmic, slow, and mixed with fast, small amplitude fast activity on the right frontal regions, followed by theta delta slowings later on, which evolve and slowly spread to the left from the right hemisphere. So it's from right to left spreading and evolve in frequency and amplitudes. Thirdly, there is a response or clinical correlation with jerks in between the EEG episodes. We have given him midazolam, but he failed to control the electrical activities, but phenobarb has suppressed this. And lastly, there are some mixed fast activity during the periodic discharges. Similarly, for non-convulsive status, sometimes we see rhythmic slow waves. And usually the frequency is less than 2.5 Hz delta rhythmic activities. How can we decide whether these rhythmic waves are in fact a non-convulsive status epilepticus? Similarly, we follow similar characteristics as we have described for periodic discharges just now. If we can see a clear onset and offsets of the rhythmic slow waves, if there are evolutions, if there are clinical correlations with jerks or any clinical signs suggestive of seizures, or if these waves improve or normalize with benzodiazepines, then we are more certain that this is likely a non-convulsive status epilepticus. The next diagnosis is severe encephalopathy with myoclonus. We often misname this as status myoclonicus and treat that as status epilepticus. These occur mostly in those with hypoxic encephalopathy. Sometimes you can see them in uremia as well, and patient will have myoclonus. EEG pattern include burst suppressions as shown in the example here, and sometimes they may have generalized periodic discharges, or in some cases with electrographic seizures, especially evolving fast activities. These patients may have myoclonic jerks, and their jerks can be subtle, can be gross, or can be segmental, or can be diffuse. If there are electrographic seizures, then the outcome is usually better because they may respond to anti-epileptic drugs. However, if there is no evolutions or no EEG pattern suggestive of seizures, as we see here with a burst suppression pattern, and the patients have elevated body stiffness during the burst, usually we know that the prognosis is poor. Aggressive treatment doesn't improve the prognosis. The next etiology I would like to discuss is autoimmune encephalitis, especially NMDAR encephalitis. The EEG can be normal initially, but when the patient started to have psychiatric cognitive dysfunctions, they may show diffuse slow waves, and these slow waves may improve or normalize with treatments. However, in about 30% of the cases, we will see an extreme delta brush pattern. The delta brush in these patterns is mainly over the frontal regions, and they are mainly consist of delta activity up to 1 to 2 Hz frequency. And on top of these delta waves, we see fast activity superimposed, especially over the downslopes of the delta waves. Delta brush can be seen in neonates, but also in NMDAR encephalitis. So in conclusions, I've described the EEG characteristics of specific coma patterns related to their severity and prognosis. However, I've also described some of the EEG patterns related to the underlying etiology. For example, triphasic waves, which has a slowing intermix in metabolic origins, but with suppressions in the hypoxic origins. I've also described periodic complexes or rhythmic slows, which can be either due to epileptic origins or without epileptic origins. And last, I have described two specific patterns. The first one is burst suppressions in severe encephalopathy with Myoclonus. And the second one is delta brush in NMDAR autoimmune encephalitis. Thank you very much.